He cares for patients that are in this room and is well loved and highly regarded, and we're anxious to hear what he has to share with us today.
Thank you so much. I have to say, it's been sort of a long and grueling process on the one hand, but for me it's been an absolutely thrilling meeting, and the kudos goes to the organizers who put in an enormous amount of work, and they're still raising money, I think, to try to pay for the whole thing. But whatever amount it is, for me personally, it's been surely worth it. This has been a fabulously good conference, a wonderful mix of parents and interested folks and professionals at all levels. And there's been a lot of exchange of ideas, both in the discussions and in the talks. So I see myself as sort of a minor add-on to all of this. I've been in the business less long than many of our other speakers, but it is an interesting process. And I think as we're trying to assemble all of these ideas, much of what we say is based on individual experience rather than carefully done double-blind studies that we hope we're going to see more and more occurring. There are different points of view on it, and all of this is going to is under constant discussion. We're talking about putting together a set of treatment guidelines coming up in the coming months, and that's going to be another major step forward. I think this meeting is being a big step forward for the whole story of PANS. In the short time I've been in this, about 3 years, I've just seen it go from what I call the year of the panda, 2014, when we first formed the consortium, to more and more knowledge, more and more interest building. So the panda is definitely growing up as we go along. So it's really exciting to be a part of this whole thing. I come at this as an infectious diseases specialist. I have to say I sort of look at this whole process of so many different specialties have been involved in this process, and it's very much like the classical story of the blind man and the elephant. We all look at this elephant from different angles, and we're trying to find out what the elephant really truly looks like and how he really truly works. So my job, much of what I'm going to say you've already heard, and I'll try to go through it a little bit fast so we can maybe get to more discussion at the end. In terms of what are the microbes associated with PANS, and obviously the connection with group A strep is by far the strongest connection, and it's made in many different ways, everything from specific stories of someone getting a strep infection followed 2 weeks later by a major rapid changes, to more not quite so solid stories, to the serology that we can have to, in some cases, to support it, and then all of Dr. Cunningham's work, which biologically links the streptococcal antigens to the antigens in the brain, and it makes a whole complete story, so that the story of the connection of streptococcus to this disease is obviously by far the clearest one. And I think that story is still only partially told. We're going to see that as we get better and better testing for streptococcal antibodies, for example, better and better testing and understanding of the streptococcal organism itself, the nature of this connection is going to become more and more clear as time goes by. And as you get further down the list, however, the connections are less clear and more anecdotal. I think the next one on my list is influenza, simply because I think most of us who are in this business have seen pretty clear-cut cases of influenza-associated PANS, in that, particularly as has been pointed out in the H1N1 epidemic years, that may be even something special about that particular strain of influenza. We don't really know, we don't have an idea why that should be. But we certainly have seen that, and it's because with influenza there's a bedside diagnostic test, and there are other diagnostic tests that are more definitive, so they get defined very well. Whereas with mycoplasma, which we've talked so much about, there's not a quick test, or at least not until very recently. There's some decent testing that's available, and a lot of it's more anecdotal, so the connection there is less clear. And we've mentioned Lyme disease several times, where the connection is still very much on the table, but the actual case descriptions in which we can really get good, solid, believable data aren't really not there. And there are probably many other microorganisms that are responsible, that are sort of on my list as an infectious diseases person, but really have a long way to go to really put all this together. So we're going to talk about Group A Streptococcus first. Apologize to you, I've abbreviated as GAS, and so you'll have to just go with that for most of the rest of the slides. Its formal name is Streptococcus pyogenes. So its association with pandas, you all know very well. The reference there is Sue's original work that defined pandas by this association, and it's held up very well. Further work, including nice study by published study by Dr. Murphy, has connected it to not only pharyngeal streptococcal infection, but also skin infections. And that is interesting because as much as we try to draw parallels between rheumatic fever and pandas, that's one where there isn't a connect, because with rheumatic fever, skin infections are not a known predisposing cause. So there are some great similarities. It's very useful to us to think about the relationships between the two, but it's also equally useful to think about where they differ. So the acquisition of Group A strep is not a simple process, as illustrated by this cartoon, and there are multiple mechanisms of attachment involved. So if we talk about the pathogenesis of the streptococcal infection, which I won't do in great detail, most of it's probably even beyond my comprehension. There are other people who know much more about this than I do. But just to show you, we know that the attachment takes place, that we know that Group A streptococci is not one thing. It has tremendous genetic variation from strain to strain. It's almost hard to find two strains that aren't from the same family that are genetically identical. There's so many ways that it varies. And as a result, there may be streptococci that are specifically related to these particular disorders. And one example might be that a streptococcus that varies in its attachment mechanism may produce a different kind of infection, a different kind of invasion, and result in a different outcome. So this is all open territory. And I think in this talk, you'll hear me emphasize as much as more of what we don't know than what we do know. And I think that's important too, because it gives some idea of where the field has to go next and where it is going next. On the host side, there are also multiple receptors, and any one of those is susceptible to genetic variation as well. So as we start to look for genetic causes or genetic associations with pandas, we'll be looking at multitudes of different host factors, including the strep attachment factors, which could turn out to be very important. So we're on the verge of being able to learn about these things as we begin to get into genetic studies, which are, as you've heard, are already underway and are as a very, very exciting way to get, I think that's going to give us a better understanding of this whole disease process. It seems likely that one of the ways in which microbes could trigger autoimmune diseases of any type is that the organism tends to have to persist. If it comes, gets cleared by these innate mechanisms that Dr. Cunningham was talking about, maybe there's less risk. But if an organism hangs around and the host keeps trying and trying to get rid of it, the chances that it's going to make antibodies that are bad antibodies rather than good ones arise. And so that anything that has to do with the persistence of the streptococci is an area of considerable interest as we're looking at its relationship to pandas. And there are multiple ways that this is possible. Two of the ones for which we have some data are first that it appears, and neither of these are complete, it appears that the streptococci can get inside of a cell and persist, where it can hide from the immune mechanisms and potentially still cause trouble or reactivate and so forth. And the second way is what's called biofilms, in which these organisms, once they've sat around in a tissue for a while, clump together and produce a film of protective material around themselves, like in a cocoon, which again protects them both from host defenses and also from antimicrobial treatment. So both of these not only lead to persistence, but also lead to evasion of host defenses and evasion of ability to be cleared by antibiotics. And so these are some of the things we think about in terms of how well the antibiotics do or do not work to get completely rid of streptococci. And so here's one study in which they claim at least to have shown that the epithelial cells in the throat actually can be shown in this photomicrograph electron microscopy, showing the organisms literally clustering inside of an epithelial cell. Another study, which is also open to criticism, but shows nice pictures at least, indicates that these biofilms can form in the tonsillar tissue. The tonsils are a hotbed of, and a wonderful home for microbes, so that the flora of normal tonsils, or at least tonsils that are taken out surgically, I guess they're not really normal, can be shown to have a multitude of organisms, just like the intestinal tract or other sites in the body that are colonized by these organisms. So that's a whole nother microenvironment that can be very complex. And it can be shown that the streptococci, or at least attempt to show that the streptococci can form these microcolonies and biofilms within the tonsils. In this picture, on the upper picture, shows the green is staining for the tonsillar crypt cells of the host, the person, whereas the red is the staining that stains for specifically for group A streptococci, and you can see how they cluster there. At the bottom picture is a scanning electron micrograph in which you can literally see the chaining streptococci all grouped together in one site. So these are processes that are very relevant to us if we're talking about how to really deal with streptococci in the condition that we care about, the pandas patients. And all of this is on the fringes of science and areas that we're going to learn more and more about in coming years, and will have direct relevance, I'm sure, for the way we manage Streptococcus. To talk a little bit, then shift gears a little bit, but to talk again about persistence, the idea of an asymptomatic infection versus a carrier. It's defined as if these are two different things, in which the asymptomatic carrier doesn't have symptoms, it doesn't spread the organism much to other people, and isn't at risk of inducing the complications such as rheumatic fever or possibly pandas. Whereas if a person can be a carrier and develop antibody responses, it tells you the host has responded, and the term bona fide asymptomatic infection has been used if you can show a child acquires streptococcus and acquires antibodies to streptococcus. That's considered a bona fide infection, and has been mentioned by Sue and others today and yesterday. This is a situation in which we know can induce rheumatic fever, and we strongly suspect by analogy likely could be related to triggering pandas as well, without ever there being a clinical sore throat or other symptoms. Studies looking at just colonization rates, in which study or the research goes through the school or a group of children and does throat swabs, show that carrier rates are quite high. So we live in a sea of streptococcus, basically, so that 5 to 15% of school kids will have strep in their throat at any given moment, more in the winter and more if there's a known outbreak. So as Sue has pointed out and others, this bug is very much with us and very difficult to avoid. And in the world of these kinds of studies, when prospective studies are done and new acquisitions are identified, about half of these do have titer rises and are bona fide, and that may be a big underestimate because the titers are not that good at picking up all of the streptococcal infections that do indeed generate an immune response. And as a result of this, in a quote-unquote bona fide infection, sequelae are still possible without the person ever knowing they had a sore throat. And rheumatic fever, which has been around for a long time and studied for many years, we know that this is true, and that these asymptomatic acquisitions account for roughly half of the cases of rheumatic fever. And then to extend that, Dr. Murphy's already talked to you about her studies that she did with Sue, in which, if I tell the story wrong, Tanya, you put up your hand or something. But the way I have it is that they got into a school during a time when there was a lot of strep going on, so they were welcome to do a study there, and they were able to do a prospective study in which they literally observed the children. They had observers in the school watching school behavior and ticking off for each child what kinds of behavioral activities or tick-like activities that children would show. and at the same time had regular repeated throat swabs to see if they were colonized with strep, and even did at intervals brief neurological exams on all the kids with a high 80-some% I think of the children in the school participated in the study, if I remember that correctly. So it's a very interesting study, and even more interesting is what they found. And I know that you showed this information yesterday, Tanya, but it's too good not to show again. And that is that they could show behavioral symptoms following streptococcal acquisition were almost 2 times more likely than those that didn't have a new streptococcal infection, and in particular those related to balance or swaying and so-called non-tick grimacing was even 3 times more likely, and the p-value of that tiny number tells you that these are highly statistically significant relationships, and they show clearly that prospectively children acquiring strep all the time in the schools, and almost none of these had symptoms with their acquisition, but nonetheless had the appearance of these neuropsychiatric symptoms that are not PANDAS symptoms per se, but they sure bear on our thinking about this. And so this sort of goes on at a low level all the time in these schools, I'm sure. Another piece of the study that I thought was very revealing and important was that they could even show over time that the children who had more than one streptococcal infection were even far more likely to develop these symptoms. So not only could they show this relationship between school-based strep, quiet, asymptomatic acquisition, and the appearance of these neuropsychiatric symptoms, but that repeated acquisitions made the situation even more prominent. So with this, we can certainly come to a conclusion that group A strep infection is associated with many cases of PANS, the PANDAS subset, obviously, of PANS that we're talking about. And even then, I think there's still more to be told about the tightness of that connection. And we've known for years about the so-called non-suppurative sequelae of streptococcal pharyngitis, and you've heard about this too, in which we know that rheumatic fever is a classical sequela that's not in itself pus-producing. It's a different kind of inflammatory disease following pharyngitis, and another of the famous ones is a totally different mechanism in which kidney disease occurs secondary to streptococcal infections, and now we can pretty clearly now add PANDAS to that list. There are many other post-streptococcal syndromes as well, but these are the main ones that we focus on. Next question is this question I alluded to earlier about, is there such a thing as a PANDAS-specific strain? We know from both the rheumatic fever studies and from the nephritis, post-streptococcal nephritis studies, that there are very specific types of streptococci that are implicated, and other streptococci do not do these things. And again, alluding to this idea that there are many different strep out there with many different properties, and some of them induce rheumatic fever, and some of them induce nephritis in some patients. And those strains are well known. What is unknown at this moment, and is another one of the very big questions, is whether there are PANDAS-specific strains. And I coined this, not having a term, I coined this term, autoencephalitic strains. I think that's a nice term that says what we're talking about in a appropriate kind of terminology. And as you've heard, several of the consortium members and others are starting to accumulate these PANDAS-related strains, in which these are organisms that are isolated near the time of the onset of the disease, especially the first-time onset. It would be particularly good, and we'll get some information about those. Interestingly, this work that's been done in this area relating to rheumatic fever, and this is described by Pat Schleuvert at Minnesota, is that he points out that all of the, I don't know the exact number, but all of the streptococcal strains that they've isolated from rheumatic fever patients have this toxin called SPEC, streptococcal pyrogenic exotoxin C. And it has the property of being what's called a super antigen. It really turns on the immune system non-specifically. And by jazzing up the immune system, his theory from that would be that this is an ideal way, we would think, to turn on these excessive responses that might lead to autoimmunity. And so that's on the table. SPEC is on the table as a specific mechanism accounting for the rheumatogenicity of those strains. And we will soon find out whether the Panda strains have this same property. And in fact, the one Panda strain I know about in which it's been sought, it has been identified to be present, and not everybody not every Streptococcus strain has this particular toxin. So this is just to give you a taste of what's ahead in terms of understanding in a more refined way what can be done. And it's even possible to imagine in your wildest dreams, and Mike Sherman and I do this imagining, that we could actually identify what are the panda-specific genes, and with modern techniques and some techniques that he and others are working on, we might even imagine there'll be a bedside test within a matter of an hour or less. We'll know if there's not only is there a strep present, but is there an encephalotogenic strep present. And that's not too far in the future. So just to review the clinical, we keep talking about some of these things, and just to show you some colored pictures, keep me and the rest of us awake. So first of all, some of the just basic statistics are that of all pharyngitis cases that appears, about 20% overall will have strep. And so that's why we emphasize someone has a sore throat in the family, you want to know if it's strep or not. There's about if all you know is that it's a sore throat, there's a 20% chance that it's streptococci. And I would emphasize we're talking sore throat in the back of the throat, or sore throat out here where the lymph nodes are, but not so much sore throat down here, which is more likely laryngitis and due to viruses. And then there's the sinusitis has been underemphasized. In fact, the American Academy of Pediatrics even says if you have a runny nose or a cough, you shouldn't even necessarily consider strep. And that may be true of cough, but it may not be true of runny nose, because that's maybe a reflection of sinusitis, which actually does associate it with streptococcus. We've already talked about skin infections. Vaginitis has been mentioned also as another potential source of streptococcal infection that could engender pandas. And then there are soft tissue infections and many other forms that strep can take, and their connection is less clear. So for pharyngitis, we look for palatal petechiae or a scarlatina rash. The throat swab is critically important, obviously, in making the diagnosis, and we emphasize over and over again, you can't do it too much, so I'll say it again, is that it has to be done vigorously. So one tonsil, posterior pharynx, the other tonsil should all be swabbed. We tell our pediatric residents, if the patient's eyes don't water and they don't gag, you haven't done it right. And that sounds brutal, but it's close to the truth. And then there are rapid tests, which you're all familiar with. Most of the ones we see are based on an immunologic test detecting the streptococcal antigen as being present. And on the future, including what I was just mentioning as a bedside test, are tests based on not detection of the strep antigens, but detection of the strep genes. And those are called molecular tests, or nucleic acid detection. And the most established one you may have heard of called polymerase chain reaction, or PCR. So here's some of the color pictures I promised. And I don't know how well it shows up, but the first one shows the characteristic beefy redness of the throat, which is the redder it is, the more likely it is to be strep. And if you can make it out, here, whoops, here on the soft palate here and there are petechiae, reddish spots, and those are very almost pathognomonic of group A strep. So if those are present, and even if the culture is negative, the chances are very good it really was strep the whole time. Reddish tongue or strawberry tongue is characteristic, and you see at the bottom a picture of the so-called scarlatina-form rash, a very fine, we always say the term sandpapery feeling, so slightly bumpy rash. And if that is present along with a pharyngitis, a red throat, that also is almost diagnostic of being streptococcus without even bothering with the throat swab. These rashes occasionally appear without a sore throat or a red throat, and then they may well be due to something else. We've had on and off discussions and emails back and forth about that question. But I think it's fair to say that with a sore throat and a scarlatina rash, the chances are good that it really is streptococcal. So And this question of sinusitis has really been underemphasized in medical circles, but the compendium of studies that have been done show that about 10% of all of all sinusitis in children can be attributed to group A strep. So this is a point at which we maybe should be considering strep or even considering doing nasal cultures. I apologize for that. I don't know if it's anything we can do. I'll try to talk over it. And then these skin infections we keep talking about. Here's some pictures so you can see what it actually looks like. Intertrigo, where you get this redness in the fold of the skin in the armpit there, the axilla. Perianal cellulitis is one of the ones that's been tied now to pandas by Tanya and others. And you can see this beefy redness around the anus with very sharp borders, and a diagnostic feature of it is that the redness goes right up to and include the anus. There's no ring of normal skin around the anus, which would happen with many types of other types of rash or even pinworm, as somebody mentioned earlier. And then there's impetigo, which can be due to staphylococcal infections, or just as often can be due to group A strep. So these are the kinds of things we look for, and you can see the golden, so-called classical golden yellow crust on the right-hand picture around this florid impetiginous lesion that this child is showing. So how good is the throat culture? And the research studies show that it's very good. You can do one swab and then do another one and show how they correlate with each other, greater than 95% sensitivity. But we know in the real world, depends who does the swab, how they do it, how rigorous they really are at doing it. So in the real world, it's probably not quite that much, and probably many streptococcal infections are read out as falsely negative because the swab isn't done well. And then, as pointed out, the idea of doing nasal cultures is sort of a maverick idea, but the data support thinking about that at least. So, and its utility for pandas diagnosis is not known, but certainly it's not unreasonable for a physician to even look for strep in nasal secretions. And that is not American Academy of Pediatrics policy at all at this point. So it's really, and it's in red because it's sort of a new idea that comes up when we're talking about pandas specifically. And then, of course, with skin or vaginitis, cultures there can be very helpful in showing what's going on. So among these rapid tests are both the immunologic ones that we usually use, as I mentioned, are based on looking for the streptococcal antigens. And we know that the sensitivity is only 85%, you see there, meaning 15% of the time it'll be falsely negative, and that's why it's so important that those cultures that are negative be sent on, why those swabs that are negative on rapid test have to be sent on for culture to pick up the rest of them that would have been missed otherwise. If they're positive, though, they're for real. And these molecular tests is a brand new concept that we can apply these techniques. And when they are done, the sensitivity and specificity are even much higher, so much so that it's being touted as a way to be able to get a test done and not even have to do the follow-up culture. But that's more for the future than it is for the present. These molecular tests show more positives than cultures in some cases, so may even be more sensitive than culture. And if it gets to that high sensitivity, cultures may not even be needed, but we're not quite there yet. It's not quite as rapid, may take an hour or two, plus longer if it has to be transported to a lab somewhere, so it's not as rapid. So we conclude that this is a good idea whose time has maybe not quite yet come. In some places it might be doable if there's a lot of business and your equipment is right there nearby. But it would really be nice to have a molecular-based test that was more rapid and that would, and hopefully not too expensive, that would give us better diagnostic testing for group A strep. There is one molecular test, the Illumagene test, that's based on this kind of DNA detection technique, and its sensitivity and specificity are indeed very high. It's just that it has those problems, as I mentioned. And oftentimes, of course, with pans and pandas, the patient may have had a sore throat before the onset that never even was seen or cultured, and it's past time for it to be meaningful. So that we often try to see if we can depend on serologic diagnosis. And that also has very limited value, but it's not completely valueless. The two tests that we have to do as blood tests are antibodies against streptococcus, are the ASO and the anti-DNase B test that I'm sure you're all familiar with. Even taken together, if they're both done, in children who have streptococcal pharyngitis, only about 2/3 or less will ever develop either one of them to be positive. So they're not nearly as sensitive as we would like. And so children who have a true streptococcal infection and don't make antibodies make up a significant minority. So we don't like missing those. And we can't entirely depend on these tests to rule it in or out. And the reverse is also true. There's so much streptococcal exposure in the schools, as we just talked about, that many kids will walk around, especially in the winter, with relatively high streptococcal antibody titers that are just incidental. And that's why Dr. Sweeto emphasizes maybe having more than one episode before you really label something as being PANDAS rather than PANS. And if you can show a rising titer between an initial sample and another one several weeks later, that, on the other hand, is considered very strongly diagnostic. So it's hard to get that done in practice, but if it can be done, it can be very useful to really pin down the diagnosis of streptococcus. It's of interest to people like me who want to know, all right, so the titer seems high. What's the natural history of these titers? And you have to go back to earlier studies from decades and decades ago to try to find that data. And there's a little bit of data that suggests that these titers generally tend to rise and then finally come back to baseline, typically by 6 months or so, may take a year. Dr. Sweeto told us about one patient that they repeatedly cultured as being negative, and still the titers stayed high. So those are exceptions. And I'm thinking, infectious disease mind is thinking maybe that streptococcus is hiding in one of those biofilms somewhere and is being missed by the cultures. A whole nother area of research to say, are there occult areas of infection that we just missed by even properly done throat swabs? And that requires carefully done studies at the time of tonsillectomy. And there are just a few of those being done that have been done, and it's hard to tease out the data. We need more studies in that area too, just to simply do tonsillar microbiology by modern means with using these molecular techniques as well as cultures to really see about how much strep is really in there that we might be missing. So as pointed out, ASO and anti-DNase B may miss prior streptococcal infection. And what would be helpful here would be to have some better antibodies that really do pick up the rest of those. And I can tell you in that area, there also is some very good things happening. And there are laboratories now that are, in an experimental way, setting up panels of as many as 15 different streptococcal antibodies, and even more in some cases with some even more sophisticated techniques. And they tell us that in preliminary look at this, that by adding more antibody tests, you can pick up more and more of those ones that were missed by the ASO and the anti-DNase B. So hopefully the time isn't too far away when we'll be studying not only these two not good enough antibodies, but have a panel of several antibodies where we can really nail down more clearly who really did have a streptococcal infection and who didn't. So really the natural history of these antibodies in pandas is not known. So it'd be nice to have a series of ASOs and anti-DNase Bs in patients with pandas that are being followed over time, or even with PANs who aren't really thought to have a streptococcal infection, may have mild or even normal range ASOs and anti-DNase Bs, and see what those are doing. And maybe with even more sophisticated panels, we'll be able to learn more about the true course of these antibodies over time. And now this too is going to be able to be done as people who are in clinics, like even in our clinic as an ID person, I follow ASO and anti-DNase B titers over time in our patients who have PANs who aren't on prophylaxis, and our patients who have PANDAS and are on prophylaxis. And I haven't got the data analyzed, but it looks like we can see these titers, even unimpressive moderate titers, drift down and down and down and down over the course of several months on the prophylaxis. At least it gives us a sense that there may be that we may be controlling strep as best as we can tell by current testing. Transmission of strep from one person to another is another area that's been studied carefully in the rheumatic, ever since people were studying strep in rheumatic fever. So we know that it pretty much requires close human contact, meaning being in a family or in schools. We know it certainly spreads as occurred with Tanya's school I mentioned. It does indeed sweep through schools winter after winter. It doesn't survive very long on environmental surfaces, so ordinary household cleaning is probably adequate. People have looked to see if animals like pet dogs are carriers. There was a time when we thought we had to culture the dogs and treat the dogs too in families with recurrent strep, and that's been studied carefully in many places, including the University of Missouri Vet School has some nice studies to show that the pets really are not important in this mix. And as far as carriage is concerned, can persist for many months, and as it's been studied, at least in many instances, the carriers are less contagious. And we talked about the school teacher who was a carrier, who probably doesn't represent a big risk to the child unless she somehow is coughing and spewing up secretions for some other reason, like an intercurrent infection. The guidelines for managing these things, for treating Group A streptococcal pharyngitis, are well set up, and the Infectious Diseases Society of America has documentation on all this. Here's a list of antibiotics I won't bore you with, except I'm interested to point out that the cephalosporins are considered alternative treatments for acute Group A streptococcal pharyngitis. Despite the fact that there are numerous studies saying that they're actually more effective than penicillin in terms of both effectively treating the strep, in terms of the numbers of patients who continue to carry strep at the end of treatment, and even the risks of relapse of streptococcus infections are all lower in this, and there's been an ongoing debate. The main proponent of this approach has been Mike Cooperstock, I think is how it's pronounced, at Rochester, and has assembled all this data in a nice study here that's sort of summarizes, a review rather, that summarizes all of those studies. And it's pretty, when you look at it all together, it's pretty impressive. So that the oral cephalosporins and these two that are circled are both first generation, so not too broad a spectrum, not too much effect on additional microbes. It's similar to maybe amoxicillin in terms of their range of microbes that they're going to hit. The other choices of antimicrobial treatment for strep are well established, but I hasten to point out that there is an emerging resistance, and I know Tanya mentioned this earlier also, to the macrolides, and there are good figures for invasive streptococci and not so good figures that I know of. And if anybody has some, please let me know, for resistance rates of pharyngeal streptococcal infections. But what we do know is that both for the macrolides, and that would include the azolides, azithromycin, and for clindamycin, there's been a gradually emerging increasing resistance, and the most recent figures I have are from 2013, a study done in Chicago only, so it's just a local study. But it does point out that these resistances are emerging and are of concern. And then we get to the question of prophylacting against streptococci in children with pandas. We've decided they really did have a streptococcal element to the story, and should they be prophylacted? And we all agree in the pandas community that yes, absolutely they should be prophylaxed, even though there's not a standard American Academy of Pediatrics guideline on this yet. We're moving towards that, and I think the day will come not too distant future when that's going to be considered the standard of care. Right now, among us, it is what we do, and we think it is the right thing to do. And so the prophylactic regimens that are recommended for our pandas patients are drawn directly from the prophylactic regimens that are well established for rheumatic fever. And the reason for giving daily prophylaxis or once a month injectable prophylaxis to give continuous protection is because so many of these, in rheumatic fever we know, so many of these episodes are induced by asymptomatic acquisition, so that if you even develop an asymptomatic infection, you may miss it. So that's the idea of having continuous prophylaxis. I have only a few minutes left, and I'm going to jump through all this practical stuff, much of which has already been talked about, including in the last hour. Vaccine is being worked on, and there's a lot of progress. There's still lots of difficulties. And I won't have time to talk about the other infections, except to tell you that none of the other infections we're talking about, including mycoplasma and Lyme disease and others, have really been clearly pinned down in good well-described, published studies, and most of this is based on our experiences and impressions, but we think that so commonly just upper respiratory tract infections, sinusitis and the like, are triggers of flares, and we don't really know why. They may be this non-specific stimulation of the immune system that we've talked about, and don't have a specific organism to disease effect, but nonetheless, certainly we all have dealt with this, know that a cold or a respiratory infection can bring this on. Sinusitis in particular might be, and that's two organisms we don't talk about, pneumococcus and H. flu may be involved there. So those are on my list of suspects, but we don't have any data to support any of those. Management of influenza, diagnosis, and mycoplasma now has a PCR test that takes a while, it has to send it off, but for the lab charges at Mayo is about 175, at ARUP it's 125 for a PCR, so it's not out of sight to really pin this down. And my main point here is that all of that's been said about mycoplasma infections inducing or related to pandas flares have been based on serologic testing, showing antibodies are appearing, and those antibody tests are not all that good. And so I'm looking forward to looking for cases in which it's demonstrated by a PCR that this organism was really truly there, not just a false positive serology, which happens a lot. And I don't know of a single case, maybe you guys do, of a pandas following a PCR proven mycoplasma infection. So it's not even really at the high level yet of showing a relationship solidly that I would like to have. I want to emphasize that vitamin D is maybe important. It's easy to recognize and treat vitamin D deficiencies. It has to do with prevention of infections. People who have low vitamin D have more infections in general, and there are theoretical reasons to believe that it also tunes down the autoimmune responses. And so although we don't know it for sure, it certainly makes sense, since it's easy to do, to monitor vitamin D levels and make sure our children all have good, solid levels of vitamin D. This is just to show that the chemical that vitamin D induces as you get increasing levels of this calyphthaloside in the system, it becomes bactericidal for group A strep in the test tube. The high levels are here that completely inhibit the growth of group A strep, and this is what goes on inside of the cells where these organisms may be infecting. And there's even a study in adults who have recurring group A streptococcal infection in Israel, in whom 92%, right button here, 92% of the patients who had recurrent group A strep were in the deficient range, less than 20 nanograms per mil of vitamin D. So it's easy to manage and treat, so we consider that something that we really ought to be doing as part of our management of children with PANS and PANDAS. And I won't go into it because my time is low, except to say that we know that vitamin D turns down, regulates the stimulated T cells, the Th17 cells that are the bad cells, and regulates up, the shift away from these bad cells, Th1 to Th2, and at the bottom helps stimulate the T regulatory cells, meaning the T cells that regulate or dampen down the immune responses. So there are good reasons to believe that that it may be beneficial. And there actually are diseases like multiple autoimmune diseases like MS, rheumatoid arthritis, juvenile diabetes, inflammatory bowel disease, in which there's a connection between low vitamin D and poor clinical course. So I've made that case as strongly as I can. And then just to wind up in the last few minutes, and I know Kristen wants me to leave some time for questions, but I have to show you, say a word about the gut, the microbiome and the gut-brain axis, because these haven't been emphasized too much yet so far in this meeting. We are in the dawn of an era of understanding the normal flora of the intestinal tract and the normal flora of the throat, because the technologies based on PCR, genetic analysis instead of cultures, are showing us now for the first time that whole picture of the incredible complexity of the normal flora of the body, and how important this is likely to be, and exactly how this works is going to be teased apart over the next decade or so. But we talk about the gut-brain axis, in which you see the blue circle at the bottom has all the bacteria. There are an average, something on the order of, we know of about 1,000 different bacterial species we each carry around in our gut. Each one of those bacteria has to have a way of attaching or colonizing and mechanisms of doing that and where it attaches to the gut. Each one of them is its own biological factory that digests things, that produces products, all of which have potential biological activity and importance in many ways. And they interact with each other, so that not just each one being important, but their interaction as a community is important. So you can see that this is a huge, huge, enormous process to be worked out. But we do know that there are communications, so that these microbes affect the whole immune system, not just the immunity at the level of the gut, but the whole body's immune system are affected by them. And similarly, the nervous system, there are tracts leading from the gut on up to the brain, and vice versa. All of that goes on. But so I will jump ahead and show you, tell you about a couple of interesting experiments that are a turn on and just an introduction to what can go on. Kristen's now tapping her watch, so I'm in trouble. But here's studies from McMaster, in which they, and this is all in mice now, gave oral antibiotics to this strain of mice, and their behavior changed. They became more exploratory, and they could show that in the hippocampus of the brain, there's changes in the chemistry of the brain just by giving an antibiotic. And furthermore, they could take a strain, the Swiss mouse, that were not so active, and transplant that were more active, and transplant them into a less active mouse strain, the Balb mice, and the Balb mice became more active and exploratory. And they did the reverse, where they took flora from the exploratory mouse and gave them to the less exploratory Swiss mice, and they became more exploratory. It tells you there's something big here, and it's all connected to the flora. The same group also found one particular, we could think of it as a probiotic strain, that was able to decrease anxiety in a mouse model, and they could show that it was working by this gut-brain axis. And another study had a model of OCD in mice, and this was at Lehigh University, in which they made the mice OCD by a certain treatment, treated them with this commonly available probiotic, and it decreased their OCD symptoms. They there's ways that the mouse psychologists can do this. And giving this lactobacillus reduced those behaviors. Again, just a tantalizing piece of information to tell us what could be ahead. I'll leave it at that. You can see that through this talk, we raised far more questions than we did answers, and I repeated a lot of things that had been said earlier about what we do know. And so now I have, what, 1 more minute for questions?
For someone who has asymptomatic strep, so we can completely not even detect it, is it possible for the carrier to eliminate the strep bacteria just through the course of days, weeks, months, and we wouldn't even know they had it?
If we can't detect it, then I can't tell you, because I don't have any way of studying it. If it's there a carrier that we can detect but has no symptoms and so forth, can we do anything about what happens to them? Yes, over time it does tend to go away, and depending on which antibiotics, and as Sue pointed out, there actually is this AAP recommendation of how you can approach that sequentially. You can treat with antibiotics and try to get rid of that carrier state a little bit quicker if you want to.
And is there any length of time that the strep will stay untreated that you can point to?
I can't tell you the exact number, but the duration of the colonization is probably measured in weeks or months, not years.
Thank you.
Okay, thank you very much.
Thank you. Hi, Dr. Cooperstock.
Hi.
When you were going through some of the slides rather quickly, I saw one that, if I caught it correctly, I believe it said cefadroxil, a possible alternative to prophylaxis. And I just found that interesting. I was wondering if you could comment on that.
Yeah, this is a bit controversial. I've taken the view that based on these studies that we know in every other setting in which Streptococcus has been treated, the first-generation cephalosporins have a better track record. So many of the patients that I take care of, I will prophylax with cefadroxil or cephalexin instead. Whether that's really the right thing to do or not, but I feel better, and I think we're likely to get better control of the Streptococcus that way. But that's a new idea, not a widely accepted one, and I would not advertise to other people that that's what they should do. I would stick primarily to the AAP recommendations.
Thank you very much.
Which is penicillin twice a day. Yeah. Okay, thank you very much.